Hi, my name is Kimberly Nugent, and today I'll be talking. Thank you for asking me to speak today with the CureDuchenne Cares. So my name is Kimberly Nugent, and I'm a genetic counselor at the Children's Hospital of San Antonio in Texas. We do have a partnership with Baylor College of Medicine, so I do have some appointments over there, but I've been here in San Antonio since 2014, and I work in a variety of clinical settings. Pediatric, a little bit of prenatal, some intensive care units, outpatient, inpatient, really all over, including one of our up-and-coming clinics, which is a neuromuscular. I've collaborated over the years with lots of other doctors here at the hospital, families, and researchers across the United States and different countries as well, which has led to a lot of collaborative publications and involvement in clinical trials and research. So I definitely appreciate the passion that families have when you're dealing with a rare diagnosis and trying to create those connections to advance not only our understanding, but potential cures and treatments for these genetic disorders. I am right now a mom of three. I have one biological son who's almost 3 years old. And then my husband and I thought we did a really good job with him. We're a little ambitious. And we decided to become foster parents. So right now we have twins. They are 14 months. So with 3 under 3, our life is a little bit crazy. So please forgive me if I mess up any words or say anything silly. It's probably sleep deprivation. I do not have any financial disclosures. Maybe one day I'll have like a mega million deal with some company, but right now I am a lowly genetic counselor, so this is a completely unbiased talk that I'm giving. And today I know this is focusing on the family unit. So with Duchenne and Becker muscular dystrophy, we're primarily thinking about the world of Duchenne. So I will probably be referring to DMD a lot because that is the name of the gene and the name of one of the names of the disorders. However, a lot of this can be applicable to Becker muscular dystrophy as well. So we're really going to be focusing on the underlying genetic cause of this and what that means, especially thinking about your family unit. And I would not be a good genetic counselor if I did not take you all back to high school biology and remind you that we have 46 chromosomes and we pair those into 23 pairs. Everything should be the same in males and females except for this very last pair. These are the sex chromosomes. So females typically have 2 X's, and then males would have an X and a Y. Otherwise, all of our genetic information should be the same or very similar across the other 22 pairs of chromosomes. And focusing on DMD, this gene is on the X chromosome. So for females, we have 2 copies of this gene. And for males, they have 1 copy because their Y chromosome does not carry a copy of the DMD gene. So when we're thinking about making the diagnosis of DMD and doing genetic testing, oftentimes that's why we see males that are a higher prevalence of males being affected than females, because females have this second copy of the chromosome. And oftentimes that is a working gene, keeping them healthy, not having any clinical manifestations of this genetic change, whereas boys do not have that second copy, and men as well. So this is why we often see that skewed proportion of boys being affected with DMD and their siblings, mothers, other counterparts that are not if they carry the second copy of the X chromosome. And when we're thinking about our chromosomes, they are these coils of tightly wound DNA. And I like to think of it kind of like when your grandmother or maybe aunt or an older woman, it's not so common anymore, is knitting and you have this great big ball of yarn. It starts off as a single string, but if you wind and wind and wind it upon itself, it can form this ball, which is a compact structure, and it's a lot less messy, not tangled. So that's kind of what our chromosomes do, is that they the DNA coils upon itself so that you have this neat compact structure to hold all of your genetic information. And when we're thinking about the DMD gene, it provides instructions for making this protein called dystrophin. And over here in this picture, dystrophin is really important because it's located primarily in the muscles we use for movement. So thinking about the cytoskeleton of your cell biology, again, taking you way back to high school biology, it provides this critical link of connections. So when we do not have that dystrophin gene that's forming properly, there isn't this connection that we need, which then causes the signs and symptoms that we see in Duchenne and Becker muscular dystrophy. And it is one of the most common forms of muscular dystrophy in boys. And depending on which statistics you look at, you could see a prevalence of about 1 in 3,500 to 1 in 5,000. Some more isolated countries and unions have a prevalence that's lower, about 1 in 18,000, but I'd say here in the United States, it's pretty good estimate, about 1 in 3,500 to 1 in 5,000 live-born males may be affected with DMD. It often has an early childhood onset, whereas Becker is a little bit more mild, a little bit later onset of symptoms and diagnosis. And again, it primarily affects the males because of those reasons we talked about with the X and Y chromosomes. One of the things I will be hitting on today is that a minority of females can be symptomatic, and this is completely variable, can vary within families, within genetic changes. It's all quite variable. So we'll spend some time today focusing on what does it mean to have this running in your family, specifically for females. And the diagnosis can be made clinically or by genetic testing. So before the age of genetic testing, we always had to rely on a clinical diagnosis. But now that we are a little bit further in our genetic testing technology, we are able to use genetic testing to our advantage to perform earlier diagnoses before symptoms arise, as well as pre-symptomatic testing. And this can be in both males and females. And when we're thinking about a person's life cycle, there really can be a lot of testing periods across that life cycle. So before conception even, if we know that something is running in the family, we can, this offers us to do testing through IVF and pre-implantation genetic testing or genetic diagnosis. So this would be where in the lab, they take the egg and the sperm, create an embryo, and then they would test those embryos for the known familial variant. If the variant is detected, they would not implant that embryo because that would be the reason for the family pursuing this option, would be to have a biological child, but to feel that as much relief of uncertainty. So trying to limit the chance that the child is affected with this disorder while still remaining your genetic lineage. You could test during pregnancy. This could include carrier screening for the mom or carrier testing for the pregnancy through chorionic villus sampling or amniocentesis. These are procedures done to test the genetics of that developing fetus or baby while the mom is still pregnant. Starting from about 12 weeks would be the earliest we would do this, all the way up until almost right before delivery. So if a family wants that information for family planning, for being prepared, choosing where to deliver, or starting the planning and preparation stage of what medical doctors or providers that child may need, these are all testing options available to any family here in the United States. You can always test after the birth of a child. So let's say you have a son or daughter with Duchenne or Becker, and you want to test the sibling. If we know that genetic change, then we can offer testing to the new sibling to confirm or exclude that diagnosis. There are a lot of testing options right now as well through either your insurance carrier, or if you are uninsured, free testing options, which I will discuss and give you some information about in a little bit as well. And throughout this talk, you'll probably hear me use the words carrier testing and carrier screening. So this is a term that we used when we're performing testing on an individual who does not yet have symptoms or features of a disorder, but is at higher risk or a possibility of carrying that genetic change. So this is sometimes what we call pre-symptomatic testing as well. And ideally, the counseling would occur before a pregnancy. However, oftentimes, if a woman does not have health insurance, she may obtain health insurance during a pregnancy, and she's talking to her OBGYN, and there's this family history of a brother, an uncle, a son, a sister with muscle issues, and that OBGYN may decide to perform carrier testing for the mom to provide more information about recurrence risk, the chance to have a child with this same disorder, or testing options of the pregnancy as well. So sometimes it can occur before you conceive a child, during carrying a child, or after the child is born. And when we're thinking about testing for females, we always try not to make it sound that testing is necessary, that it's something you're being forced into, that it's something you have to do. We like to help people make autonomous decisions for themselves and really weigh out the risks and benefits and limitations to make sure that they're doing the right thing for themselves at that point in time. However, as a genetic counselor, I do bring up the testing option for females in the family, whether that is a sister, a mom, an aunt, just to consider that and determine if this genetic change that we have identified in the family is new to a child or possibly inherited from a parent. Just some minute details of testing. Most of the time, we're thinking about deletions or duplications of this gene. However, there can also be little spelling changes or sequence variants in the gene. If we're thinking about the DMD gene, like a book, books often have lots of chapters and thousands of words in that book. The DMD gene specifically has 79 chapters in it, or 79 exons. And within those 79 chapters, there are thousands and thousands of little letters, our genetic alphabet. So most of the time, about 60 to 80% of the time, this is going to be a deletion or duplication where we're taking out chapters, we're rearranging those chapters, we're adding in extra chapters that cause that book to not make any sense. But sometimes there can be a spelling change in the gene that can cause the same effect. So just imagine that you have this 79 chapter book, and in chapter 50, all of a sudden it ends. You read at the end of chapter 50, the end. Even though the rest of that information may be past that point, so chapters 51 through 79, if you're reading the end, you're not going to think to read any further. So this is kind of how those genetic changes can affect our genes by causing them to not work properly or be transcribed or read properly. When we're thinking about testing for females, you may have heard of a test called a CK, or creatine kinase, and this is a test that looks at a muscle enzyme, kind of just tells us how those muscles are working. Is it working properly? Are we at a good range? Or if it's elevated, that tells us that something's not quite working as we would expect and something's different in that muscle pathway. However, this is a very imperfect screening test for females. And if inherited, this genetic change can affect both recurrence risk and medical management that we would give to females. So for this slide, I spent a lot of time trying to find these exact numbers, and no matter which website you look at, which publication you read, which country you look at, it may all be different. So I tried to find the most common numbers and provide the averages, which seem to be the most frequent. So carrier frequency is the percentage of a population that's thought to be a silent carrier for this disorder. So speaking about DMD specifically, carrier frequency would be for women who carry that genetic change but don't have any overt signs or symptoms or affected with a severe clinical presentation of DMD. And this can vary by ethnicity, country of origin, but on average here in the United States, we'd say that the carrier frequency can be as high as 1 in 500. A good average number is about 1 in 677 to 1 in 717. So if we're thinking about that, if we have 1,000 women in the same room back before COVID, when we could all have large gatherings or go to concerts or sporting events, you're thinking about the thousands of people that are there together. Several hundred of those women, if we're thinking about a basketball stadium, may be carriers for Duchenne muscular dystrophy, but it may have never occurred in the family, or it may have been mild in the sister. So for this reason, carrier testing is becoming more and more frequent because we know that it's out there, and without showing overt signs or symptoms, it's really hard to know what your genes say unless we take a look. When we're thinking about a child who has Duchenne, about 2/3 of the time, and these are again rough estimates, but they tend to be true, a mom of a son has that genetic change. So that makes her a carrier if she carries that change. So 1/3 of the time, if we have, that would mean that the mom does not carry the change, and this is de novo or new to the child, not inherited from mom or dad. So when we're thinking about these, we always bring up the idea of testing for family members, for siblings. Sometimes it's not an option to test a parent, but we may bring up the idea of testing sisters, because we know that even without testing parent to confirm whether they do or do not carry the change, there is an empiric risk that that sister may be an unaffected carrier, and if she's of childbearing age, that should be something I feel like she should be aware of. And you don't have to look at this small writing on these slides, but I liked these two pictures because there was this study in 2010, and they tried to do a really broad overview of all the Duchenne registries, and it showed that everyone of different ethnicities here in the United States can be a carrier for DMD. So Hispanics, not Hispanic white, or we'd say not Latino white now, and African American or Black as well. So those are probably the three main ethnic groups that they looked at. We know that this can occur in Asian heritage, European heritage. Every ethnicity can be a carrier for Duchenne. We know it's something that can occur across the globe. And thinking about the different types of genetic changes over here on the right, we talked about sometimes there's deletions, duplications, or spelling changes, that it doesn't seem to matter which type of genetic change is running in the family. All of those, there's a chance that it could have been inherited from a family member. So just because your child has one type of genetic change doesn't guarantee that the parent is or is not a carrier for that change as well. So jumping back to the X chromosome, I'm a big fan of pictures. I'm a very visual learner, and I feel like this helps me talk to families. If we're thinking about our X chromosomes in mom and our X and a Y chromosome in dad, so this change over here, this half, the white half, is the one with a change in it, and the blue sides are the genes that are working, because mom has 2 copies of this gene, dad has 1. So every time you have a child, you're passing on half of your genetic information. Mom is going to pass on half, and dad is going to pass on half of his. So mom will never pass on both X's, dad will never pass on an X and a Y. We do know that mom will always pass on a X. So she only has 2 X's to give. She will always pass on one of the X's. And dad will either pass on the X or he will pass on the Y. So it's actually the dad's genetic material that determines if the sex of the baby is male or female. And when we're thinking about that, mom's passing on half of her genetic information. There's a 50% chance that she may pass on the non-working copy. If dad provides an X, that means that it's a carrier female, just like mom. If it's a boy, then that means that child could have Duchenne, most likely would have Duchenne, I should say. And if mom passes on the second copy of the X that has the gene that is working, and dad is not affected with Duchenne, that's an important caveat that I didn't state before. We're assuming dad is completely unaffected. Then they will either have a son who does not have Duchenne or a daughter who does not have Duchenne and is not a carrier. So even though we're thinking about proportions in half and half, mom provides half, dad provides half, there's actually 4 possibilities for each pregnancy. And each pregnancy is kind of a new flip of a coin. So just because your first son had Duchenne doesn't guarantee that your next child will not. It's a completely independent sorting every time. And it's very similar to wanting a boy or girl. You may really want a boy, you may really want a girl. You may have heard wives' tales about jars of pickles under the bed or window facing east or all sorts of crazy things. But that doesn't really make a difference when that child is conceived. So by the time you realize that you are pregnant with a child, all of the baby's genetics are already set and done, and it is what it is. So oftentimes we feel that we did something wrong. We did or did not provide the good gene or the bad gene, or, you know, my child's going to go bald because their dad went bald. But that's nothing that we can control. It's just a completely random assortment with each pregnancy. And we went over this a little bit earlier, but I wanted to provide y'all with some verbiage in case I talk in circles, which sometimes I do, that for this second copy of the X chromosome, oftentimes that's what helps females be unaffected or asymptomatic carriers. If we're thinking about drawing out a family tree, which I do when I see all my patients, because that's such an important part of who we are, is our family unit and the genetics from where we come. Let's say that this is my patient down here, this little guy way down here, and he has Duchenne. And I'm taking the family history, and he has one brother who's healthy and one sister who's healthy. Well, if I was just to ask about mom, dad, and the siblings, that wouldn't necessarily give me a great idea of if this was something inherited or possibly something that's running in the family. But if I expand on that and I learn about mom's brothers and sisters, I may learn that mom has this brother over here that also has Duchenne. And then mom's uncles on mom's side, so maternal uncles to the mother here, these maternal uncles also had Duchenne. And then there's this great uncle with Duchenne. And if we're looking at this pedigree or family history and trying to make sense of this, we can infer that these women with the dot in the middle of their circles are obligate carriers. And though they've had no genetic testing, we know that they are the common link between these affected males. They are the X chromosome that's being passed down in the family. And from that, we can pretty accurately observe that they likely carry this genetic change. And we would counsel them as such, that I would counsel this mom down here that she does indeed carry this genetic change. And if she's having another child, there's a 50-50 chance. If this child is clinically asymptomatic, not expressing any concerns for Duchenne, he's likely unaffected. However, this girl probably is at 50% risk or chance of having the same genetic change that can cause Duchenne as the brother over here. So that's how sometimes we can infer that family members who have not been seen in clinic or had testing may be a carrier of this genetic disorder as well. And when we're thinking about why do some females have symptoms, why do some females not, it is through this process of what we call skewed X-inactivation. And again, this is going back to high school, back to college biology. If any of you were lucky enough to suffer through that with me, that for the women who have 2 copies of the X chromosome, 1 copy of the X chromosome is inactivated. It's kind of just turned off and put on pause and kind of sits in the corner waiting to be called upon. So 1 copy of the X chromosome is working and fully functional in most of these cells. And oftentimes this happens randomly. But sometimes if we know there is a genetic change, or I say we, our bodies are innately smart. If our body is aware of this genetic change and that gene's not working well, that may be the copy of the gene or the chromosome that is inactivated or turned off. However, sometimes that doesn't happen, and the copy of the X chromosome that is being expressed is the one with the genetic change. So this is how some women may be carriers, but not have symptoms because the healthy copy of that gene is working, producing the dystrophin protein that's keeping our muscles healthy and doing their job properly. And some women may show signs or symptoms of that at variable ages because it depends on which copy of that gene is being expressed. And that is really, really, really tricky to tell because unless we do a biopsy of muscles, a biopsy of the heart, the skin, the lungs, all our different organs, it'd be really tough to say which copy of that gene is being expressed in those females and which ones we should pursue screenings for. So I did go over these numbers a little bit on the previous page, but one thing is this middle bullet, that if we do genetic testing and mom is not a carrier, it doesn't necessarily guarantee that the chance to have another child with the same condition is completely 0. Through this phenomenon called gonadal mosaicism, oftentimes there are case reports of families whose parents have tested negative for this in their blood. They don't have this genetic change in their blood, but they go on to have multiple children who do have the same condition and are, we've confirmed biological parentage. So we know mom's the mom, dad's the dad, and their blood is negative, but they have 1 or 2 or more children with the same genetic disorder. So this is when the ovaries or the sperm cells, so the ovaries that contain the egg, the testicles that contain the sperm, those cells have the genetic change, but it's not present anywhere else in the rest of the body. And this happens very rarely, not very often. As I said previously, that was a mistake, but it can occur. So for that reason, we never give a 0 or 100% number in genetics. So we'd say the chance to have a child with the same condition if mom tests negative is low, but not 0. So we'd say less than 1%, maybe up to 8 to 9%. Because if we take 100 families who have Duchenne, where mom is not the carrier, about 8 to 9 times, we may see that they have another child with the same condition, even though mom has tested negative. So I'm not trying to scare you or add extra worry. I just wanted you to know additional information so that if you are thinking about having more kids, you've had testing and it's negative, it still might be worth talking to your OBGYN or your other child's doctor for additional screening or testing, just to provide peace of mind if that's something that's going to make you very anxious about the uncertainty of that. And I did talk about this also, but I've forgotten I put in some pictures. Pictures are wonderful and amazing. So hopefully you'll be able to look back on these if you have any additional questions. And I also put this one in because with these new cures and treatments, men and boys are living longer, thinking about having children of their own. And if a man has Duchenne or Becker, we know that there's a 50% chance of passing that on. However, if we're thinking about the chromosomes that dad passes on, he's 50% chance that he would pass on an X. Mom is always going to pass on an X. So if he does have children, there'd be a 50% chance that the girls would be carriers. So if he does have a girl, she would be a carrier for Duchenne. If he passes on the Y, that does not carry the copy of the Duchenne gene, and he would have unaffected boys or boys without Duchenne or Becker. So this is something I put in because I feel like it's important for those older individuals who are thinking about having families of their own, because while you may not have a son who is affected with Duchenne or Becker, like the father, sometimes there can be a lot of guilt thinking about, I'm giving this to my daughter, will she show symptoms or signs, and what does that mean when she's having children? So I still feel like that's an important conversation to have with families and boys who are of reproductive age. So thinking about carrier females and what are the medical things that we need to do specifically for carrier females, because I feel like we spend a lot of time counseling families about what they need to do for their sons, for their brothers, for their other family members, but moms, we often forget to take care of ourselves. And I know I am preaching to the choir because I have 3 under 3 right now, and I am the last person I take care of. But that is something that needs to be made a priority, or at least on the top 5 list, because there is an increased chance for heart conditions. We know that the heart is a very important muscle in your body, and dystrophin is present in the heart. So we do recommend that women undergo cardiac surveillance if we know that they are a carrier. If we do not know that they're a carrier, if genetic testing has not been performed and we cannot definitively rule out that possibility, it's not a bad idea for those people to also have cardiac surveillance. And this is even without symptoms. Obviously, if you're having chest pain, palpitations, other heart concerns, shortness of breath, you certainly want to go see the cardiologist sooner than later. But even if you are a completely healthy person, you're running half marathons or doing all sorts of crazy, aerobic exercises where you're in great shape, it'd still be important to go to the cardiologist. We also monitor for scoliosis. This is something that we do for all children of any age, because as our bodies are growing, our spine is growing. If we start to get a little curve, the spine, we're growing at a fast rate as children, and that can kind of take off very quickly. We also monitor for additional education needs. The dystrophin gene is present and expressed in the brain in a smaller proportion. So sometimes learning disabilities or other behavioral differences have been seen in both boys and girls who carry this genetic change. Excuse me. If there's a concern for muscle fatigue, developmental delays, cramping, anything like that, you should definitely consider, the providers should consider a CK or looking at that muscle enzyme to see how that enzyme is working. If someone does have muscle weakness or fatigue easily, we'll think about things like physical therapy or other therapies to help improve that muscle tone and provide stability for those joints and bones. And then, of course, as a genetic counselor, I feel like it's very beneficial to come speak to a genetic counselor before conception, during pregnancy, whatever point in your life you can find a genetic counselor. I feel like that's something that could be beneficial and provide this conversation and be able to answer all your questions so that you feel comfortable in the knowledge and empowerment of that knowledge to take care of yourself and your family. So there are a few papers I was reading through, and I put these in, so don't worry, there's not going to be a quiz on like high school biology, but I did like how this summarized some of the information, which I feel like it's meaningful. We can always say that there's a higher chance of something happening, but what are those actual numbers? And these, while they are from about 2-3 years ago, they're fairly recent. So it confirmed that about 60 or 2/3% of the time, moms are found to be carriers. We do see an elevated CK level in some women who are having symptoms, but again, not a perfect screening tool. If a woman has a CK and it's negative, that doesn't definitively rule out that she does not have that genetic change. The researchers who wrote this article classify this as obvious and somewhat progressive muscle weakness by report, and that was present in about 17%. So some people do report a little bit of muscle weakness. Again, someone's physical aptitudes may vary within a family, so it's tough to say exactly what that is. But the fact that they felt like it was progressive or it got a little bit worse with time was pretty consistent among those who reported this. The cardiomyopathy or enlargement of the heart was present in 60%. And this is not something that you can see from the outside. Sometimes on a chest x-ray, if you have a pneumonia, you might pick up heart enlargement, but most of the time the best method of screening this is for an ultrasound of the heart. So just like when you're pregnant, they put on a little goo and do the ultrasound on the outside of your chest here to look at the heart muscle. Further imaging may occur, and that can be something like a cardiac MRI or CT. And they did show that the muscle of the heart seemed to change over time, that it became a little bit more dense, a little bit less flexible and pliable, and which made the beating of the heart a little bit more difficult. So nothing that these women experienced clinically, no symptoms they were feeling, but they were able to see that there are because of this genetic change these women carry, there can be clinical changes to the heart as well. So definitely warrants screening. So I can say that you should go get cardiac screening, you should do that, but there's a lot of reasons why that doesn't always come to fruition. And I appreciated this article that kind of summarized those. So they did structured phone interviews with women who are known carriers for Duchenne and Becker muscular dystrophy, trying to sort out the themes or ideas of what are the things that are keeping you from undergoing cardiac and otherwise medical surveillance and screening to keep your, because again, the idea is to keep yourself healthy. So if we can identify those, what are the things that we can put in place to reduce that or to nullify those barriers? And the first and most prominent was lack of awareness among health providers. So a woman can go see her primary, she can go see her OB/GYN if she's pregnant and say, my son has Duchenne, I'm a carrier. But if that doctor or provider doesn't know what to do with that information, nothing's going to happen. So it is important, education, self-advocacy to make sure that that happens. And because that ties in directly to number two, they felt like there was this great responsibility to be their own advocate. They went to this medically trained provider and they didn't know what to do. So it was a burden for these women to have to provide education to every medical provider that they saw. There was some frustration with misinformation received, and I'm not sure, it didn't clarify whether that was at the time of diagnosis, their child or sibling's diagnosis, or misinformation that they obtained from a website, misinformation from a provider that they saw that they don't need to worry about it, just that there was no consistent information available, that you always need to do something, that you never need to do something, at what age do you start doing something. That was frustrating for the women. Another would be lack of concern due to family history or perceived healthy lifestyle. So even if you are a person that is very active and fit and runs a marathon, you can still be developing these silent cardiac changes, which could eventually be very problematic for you. If you're looking at the family history and you say, well, my mom's a carrier, I have brothers who are affected, I know she's a carrier, she passed away in her 80s and she was completely healthy, so I'm going to be healthy. That's not always true. Just like we talked about with the Skewed X-inactivation, where not everyone who has that genetic change expresses it in the same cells, we can't guarantee that just because a family member who is also a carrier was healthy and lived a very long life, that that's going to be the true for other women and the same, depending on what's running in the family. So for that reason, it is important to at least have those conversations and be aware. Lack of information sharing with carriers in the family. Most of the time, families are so focused on the child who or person who has this disorder, who has Duchenne, what are their medical needs, what's going on with them, that it kind of slips our mind to inform our siblings that, hey, I'm a carrier, you should have carrier testing, you should consider that, your kids could be at risk, blah, blah, blah. So a lot of times that information was not clearly relayed. And then prioritizing the healthcare needs of others. Again, moms, we know this, that we're so busy taking care of everyone else, it's hard for us to fit in time to take care of ourselves. I really love people who tell me, don't forget to take care of yourself. Like, in what time? In my free time, I try to sleep. And that's as much, of a hobby as I have right now, is just trying to find time to get enough sleep to function. So that is definitely something that I feel like we need to continue working on, is the building those relationships to take better care of carrier mothers when they have such an intense financial, emotional time burden of caring for these children with Duchenne. And there was also an overall theme that the conversations about carrier status should begin at a younger age. So similar to how older generations never talked about health concerns, they never talked about cancer because they didn't want to burden anyone, the more open we are with these conversations and these topics and starting at a younger age, those are all greatly beneficial for future generations. So this, I won't spend as much time on this one, but it just showed that the average age at which people became aware of their carrier status was around 11, and they had carrier testing at around 15 years of age on average. These women do feel like it helped alleviate uncertainty and that they were able to make that autonomous decision. So even though they were still adolescents, still teens, they felt like they weren't being pressured into this decision. So that was 75%, which means that 3 out of 12 did feel like they were being pressured, or maybe this was not the right decision for them. So that's why I feel like these open conversations, being able to talk about everything, is very important. So there are lots of different types of test results. It's not always a negative or a positive. Sometimes we can have uncertain answers that are in the middle as well. So it's important to have a good relationship with the provider who's ordering the testing to make sure that you're fully understanding everything. And this is just in general, thinking about genetic testing. There are benefits and risks or limitations to doing testing. A lot of times we feel that the benefits outweigh the risks, but it can be very individual depending on the person. So some things that I like to talk through with people who are considering testing are, am I mentally ready? Am I at a spot in my life where I am okay to handle this information? And talking out, how are we going to use this information? How am I going to change my life if this is positive? Will I think differently of myself? Will I make different life decisions? And what if I'm negative? Am I going to be okay with that, knowing that this is something that I more or less escaped in the family? Or the unknown status of, I know I'm a carrier now, but I don't know if I will develop cardiac issues in the future. Are those all things that you are ready to handle and potentially learn? So this study is a bit older, it's from '97, but a lot of these ideas and themes are still true today, where a lot of times if someone tests positive or negative, it provides that relief from uncertainty. So that burden has been lifted. That burden of unknown has been lifted. So they can take this, adopt it, and plan for the future. Just move on, whether it's a yes or a no, we're able to move on from this limbo. However, there are a lot of feelings of guilt. One of those that we don't think about very often is survivor's guilt, where if something is running in the family, that why did I not get this, but my brother, who's this perfect person, did get this? I feel guilty. I don't want to share this information because I would feel guilty celebrating the fact that I did not get this when other people in my family did. A lot of parents, again, we feel a lot of guilt and worry and angst about everything in our children's lives, but the guilt of potentially passing this on to future generations. So not only did I give this to my son, my daughter's a carrier, and now I'm worried about my grandchildren. Because oftentimes it's not just a a stepwise thought. It's like a completely linear thought where it just keeps going and going and going, and you're worrying about all of these possibilities. Sometimes there can be additional stress relaying information to family members of, let's say I am a carrier and I go and talk to my sister about that. Well, she's going to ask me, what does that mean? What do I need to do now? Who should she go see? What does she need to do? So a lot of times as the middle person, you're kind of bombarded with all of these questions about what to do and where to go and how to deal with that. So if you are interested in genetic testing, I would say definitely talk to your DMD provider. So I made that very generic, whoever is the person that you are most comfortable with and is most comfortable with DMD knowledge. The most familiar, that could be a neurologist, a nurse practitioner, your general PCP, a genetics professional, whoever that is, just talk to them about your interest in pursuing this for yourself and if they can help you identify which route to take. Because ideally there would be that identified genetic change in the family so that when we do carrier testing, we can say a definitive yes or no. It is there, it is not there. However, this is not a requirement. Testing can be a blood draw or a cheek swab. Our testing technology is getting better now, a little bit more robust. So we are able to accept cheek swabs, which just take a little bit of cells off the lining of your cheek and test that DNA. And again, as a genetic counselor, I feel like it's very important to have pre and post-test counseling just to help walk through that, make sure that this is an autonomous decision and that you're ready to know all this information. If you do not have health insurance, some labs can offer free cascade testing. So let's say I see a child in clinic and I feel strongly that they have Duchenne. I do genetic testing, which confirms that. And this lab offers free familial testing for moms and siblings for a certain amount of days. That is true for many labs now. And there's also several free or sponsored testing options where if you do not have health insurance, but you want to know this information, that can be arranged for you. Oh, and then talking to your kids. There is no perfect recipe, no perfect time, no perfect plan to make this happen. It seems to work best when you talk little by little, like I'm taking your brother to the appointment, and next week I have to go to the appointment because I carry this gene change too. So I need to go have my heart looked at next week. Just bringing things up little by little, normalizing it, and that way it's less scary. If this is something we know about, then we know what to do, how to screen, and something that we can take action on. You also have to think about your child, how do they handle new information, and tailor that conversation to your child's understanding and interest. And I feel like some of our families schedule extra appointments, or we may not be due to see them, but their child has lots of questions and they don't know how to answer that. Of course, come talk to your DMD provider so that we can help with those conversations and facilitate that information. There's a lot of great resources out there. One of the previous things, which is not so much a concern right now, was genetic discrimination. So in 2008, enacted in 2009, GINA, the Genetic Information Non-Discrimination Act, occurred, and it protects against insurability and employability. So insurance companies can't discriminate against you, can't drop you, raise your rate based on something that might happen, different than a pre-existing condition. As well as if your employer was to ever learn about a genetic predisposition, they can't fire you, refuse to hire you, do anything like that based on something that might happen. And there are two caveats. This does not protect against long-term care and life insurance. So those are things, if you're thinking about obtaining those prior to testing, that would be a good idea because while your genetic results are not released to anyone, they may potentially ask about that. It also does not apply to those in the military or companies that employ less than 15 individuals. And you can go to ginahelp.org for more information if that's something that you're interested in. All right, so I'm going to pause because I can completely talk about this all day, but I think I've already overpassed my time limit. So Tiffany and Carrie.
Hi.
Hi. Oh.
What a fantastic overview, Kimberly.